I'd love to welcome everybody, and let's just have a fun night. We'll answer as many questions as we can. I'm really an information kind of guy, and I teach diagnostics, and I love diagnostics. And tonight's course is 3D imaging. Today's Explorer in diagnostics, not for caries, but for a heck of a lot more. So, most of the time, money comes in at the end of a course, and I think the heck with that. Let's talk money. Let's talk ROI. Why would you invest in a cone beam? And tonight I'm going to show you why. I couldn't imagine not having a cone beam. And honestly, I think if I flash forward in 5 years, I think X% of dentists will have them as the standard of care in dentistry, and you'll see why tonight. But let's talk ROI. There's two types of ROI. Your fees for imaging and the fees for accepted treatment. I'll end tonight with, no, not yet, you're not that lucky. I'm gonna end tonight with how do you wow a new patient? That new patient can go to 5 dentists, how do you wow them to stay? I think cone beams are critical when you're talking complex casework. But that's fees for accepted treatment. Let's talk fees for imaging. There are 3 codes. Most people use 1 code, which is ridiculous. We charge 3 fees. Routinely, it's $125 and $200, which are most of our scans. And then $350 is when we do a full TMJ, a big scan. And then I have to send it out to beam readers or reading service because I want them to cover my butts. Because if you take an image, you're responsible for reading that whole image, and reading sinuses and nasum and all that stuff, that's just not my bag. So there are 3 fees, and we kind of waive the fee if an implant is done. We just do. We're looking at it, it's a $4,000 to $5,000 procedure. We take the scan, and if the patient signs up, that scan is waived. We're looking at medical billing. We're actually starting medical billing in 2 weeks. It's a interesting endeavor. The reimbursements for cone beams are 2 to 3 times what we're charging right now. And how many cone beams do you take in a month? So this morning, I knew I was presenting today. I just went onto the Prexion site, and I saw that we had taken 42 scans as of today, and that's on the lower right scan, the lower right-hand portion of the slide. So when you look at this, I got to tell you, we'll get to the next slide of financing. If you're doing 30 to 40 scans a month, we were referring out at least 15 to 20, and we were just referring them out 3 years ago, waiting for the CDs to come back, and it was just so tiring. So you look at the numbers. When I bought my Prexion, it's a 4.9%, or at least mine was 4.99% interest rate. I have 2 cone beams, by the way. My previous one was through Henry Schein at 6.4%. I would shop well, by the way. My payments are $1,600 a month for 5 years. Donald and Barack gave us great tax deductions, and your accountant will tell you such. So when I look at 30 scans a month, if I'm billing out 40 scans a month, I'm absolutely billing out $3,000 to $5,000 a month in scans. Just saying, that's the money side of this. But as you're going to see in the next 45 minutes, if you're doing 15 scans a month, you're beyond breaking even because there's so much clinical work that you're just going to score on. And that's really what the bottom line comes to. How much business can you close? So tonight it's really the world of cone beams. So let's just put aside the $1,600 a month payment or 10 or 15 scans a month. Let's talk the world of cone beams. And I really believe 3D delivers an expanded view of 2D. You can't live without 2D x-rays, of course not. But here's my point. In 10 minutes, and 10 minutes is a really critical time frame, from the time my assistant scans the patient, which takes about 3 to 5 minutes total, getting the patient in there, doing everything, and then literally the image is ready to be read. But I'm about a little ways from my scanning room, By the time the patient comes back to me, I'm within 10 minutes reading everything with the patient in my operatory or in my office. And I'm the general dentist. I am a general dentist in a multi-group specialty practice. And I absolutely believe I deliver far better care by having cone beam technology in my office, and I have two. So the questions, let them begin. 2D versus 3D. How many periodontic situations do you see yearly that you want more information on? Patients breaking down. Why are they breaking down? Do you see everything? So this is a patient, Anita. I'm going to cover her tonight. She had 5mm pockets in the between 2 and 3. And my hygienist comes in while I'm working on a patient, says, you need to see Anita. She's breaking down fast. And what was interesting is she was wearing Perio Protect trays. And here's my plug for Perio Protect. If you're not using Perio Protect, and you go to perioprotect.com, it is unbelievable how we treat refractory disease and so much more in our practice with Perio Protect. But aside from that, if a patient's not getting better in Perio Protect, we had to figure out why. Now look at this 2D x-ray and tell me anything's jumping at you. Honestly, there's nothing jumping at you. Same day, 3D. Look at that. We'll get to it. It's a sagittal view, 5x5 field of view, high def. Are you kidding me? Look at the difference. How long had this been going on? I had just totally missed this. I could have caught this 6 months earlier, but I had no idea. They were 5mm pockets that had erupted into 7s to 9s. Next question, how many extractions do you see in your practice yearly that are pre-implant, that you need to make decisions on how to sequence the treatment? This is James. He's an 82-year-old patient. I'm going to show you his case tonight. Look at the 2D image. The patient came in with a loose post and core on recall. You see nothing except a pneumatized sinus. On the right, another 5x5 scan in the coronal view. And now you can start to see the abscess wrapping from buccal to lingual. So now are you gonna redo a post and core, a graft, sinus, implant placement? We're gonna get into that later tonight. How many endodontic and failing endodontic situations do you see? Yeah, I know endo works, but so many of the times you have these questions. This is David. He comes in at recall, a little tenderness. And you look at this, and I scan him, and in the middle shot from an axial view, and we're going to get into this, you see the 3 little bright white points, and there's the mesiobuccal. Well, there's the mesiobuccal too that's not been filled. As you scroll down a little deeper, here's the abscess, not spreading to the distal, not to the palatal, to the mesial. So what do? We're going to talk about it later. What's the literature say? How many fractured teeth do you see yearly in your practice? What's the literature say on that? How many fractures would you want to have more information on? So here's a patient with number 12. Tenderness to palpation, saw my associate while I was away. He adjusted the bite and said, yeah, there's some probings, but let's see, maybe it's in traumatic occlusion. Why would this be in traumatic occlusion? Cone beam scan, sagittal view, here's your crack. Lesson learned, my associate now knows and has been trained to take a CBCT. How many vague pathologies require better imaging? External and internal resorption cases. I can't tell you how many of these cases are happening, and 3D is essential. Everybody out there who's listening to this has seen external and internal resorptions. What's the number one cause for external and internal resorption? And you're going to say trauma, but what's the trauma? And the trauma is orthodontics. Last year alone, I think we diagnosed over 40 cases in our practice. And of the 40 cases, over 30 to 35 had ortho. Of the ortho, it was 30 to 40 years later that we're seeing these. Let's take a look. So here's Dan. So tooth number 22, here's your periapical, nothing apically. He totally has no symptoms. My hygienist gets a stick and she thinks it's a class 5. I look at this and I go, that is not typical of a class 5 decay. We take a scan. We're going to go over this case. How do you treat these? Here's the scan, and here's the money view. I can now see the resorption external. Does it involve the nerve? Stay tuned. Patient had no symptoms. How do you not have a cone beam? How often do you need more information before treatment in regards to wisdom teeth, impactions, or supernumerary teeth? I had an 18-year-old kid come to see me last year. Lower left sensitivity. Lower left sensitivity. Now, the protocol in my practice, for those of you who have heard me speak, is I don't take x-rays. I don't take bite wings on kids who are 18 unless I need a bite wing or a periapical. I use Carry View and Spectra. I use loops and lights. All three are far more diagnostic than an Explorer and a bite wing x-ray. I save all the images. This is how I work up my patients. And routinely in the past, I'll take a Panorex to evaluate thirds when they're 16 years old. I may take something different when they're 12 if they have eruption problems, but that's my protocol. And the question is, on an 18-year-old, do I really need a periapical? Do I need a bite wing? In this case, I wanted to see the extent of the caries that was causing his sensitivity. And there's his extent. So now the question is, for all my audience out there who's also heard me, my goal in life is keeping teeth till their 85th birthday. Now, who in their right mind thinks if you're going to treat number 18, you take out 17, how are you going to save that tooth, 18? It's going to need a root canal. What kind of margins are you going to have on the distal? And can you really save tooth number 18 till this patient's 85th birthday? That's my goal, saving teeth to their 85th birthday. So I just want to show you that there's so much more data when you're looking at CBCTs than a Panorex. This is a low resolution image. This is in my predecessor before Prexion. I still want to show you what CBCTs really do. So there's your wisdom tooth. There's the other side. And there's the decay. Now, I'd already mapped the nerves. It's easy enough. It takes 5 minutes, really, once you're trained with these technologies to map a nerve. And the oral surgeon said it was no problem taking out the wisdom teeth. But was that the best option? So I sent the images, I should say, and the DICOM data to my oral surgeon and my orthodontist. And they said, what should we do? Well, this is what we did. We ended up extracting 116, 18, and 32. And my orthodontist said, I'm going to bring 17 in. It's a virgin tooth. I'll get it into an alignment that it looks like 18. I would never have done this 5 years ago. 5 years ago, I would have referred this to my oral surgeon. He takes out 4 wisdom teeth. We end up doing a root canal probably ultimately on 18 on this kid. And ultimately, we lose the tooth 30 years later, 20 years later. It's just the way it is. This is how cone beams really impact my practice. It's amazing. And then with Jeff Horowitz and many of our wonderful Catapult guys, they are just guiding me into TMJ sleep and airway issues. So I'm 60, and I'm already on my second cone beam. And I have to tell you, it's about changing, offering your patients the best diagnostics possible. And I really think it's really important because At 60 and still enjoying the game, if I can diagnose patients earlier and up my game in diagnostics, can we all redefine our approach to care? And the answer is absolutely yes. So here's my mantra. We got changing times. You got PPOs, you got corporate dentistry. How do you separate your practice as really a wonderful value-added practitioner who's going to diagnose your patients and create more efficient diagnostics that result in better decision-making and ultimately a higher quality of care for your patient? Ultimately, this lowers the cost to the patient by creating the best treatment plan for the patient with the highest chance of success, just like the last case with number 17 substituting for 18, because that was best. That was absolutely best in the long term. So my bottom line for modern day diagnostics is to lower the cost of ultimate care to my patients, increase the efficiency of care, and equally raise the quality of care. Never a compromise in quality. But if I can be more efficient, diagnose much faster, and diagnose much better, does that not ultimately lower the cost of the care to the patient? Because this is my mantra. I got to get this kid to his age, this woman to her mother's age, and I need better diagnostics. I can't tell you if a cone beam is right for you. I don't know your practice. But diagnostics today can be customized to each office's focus. Diagnostics should be specific to each patient. Diagnostics should be all to the betterment of our patients. So where are we today? It's crazy where we are. Digital x-rays, they're the norm. Stop it, they're the norm. We use fluorescence in my office. We use Air Technique Spectra. We don't use Explorers. Are you kidding me? Explorers are 50% diagnostic. Seriously. Explorers and traditional bite wing x-rays were launched over 100 years ago when Woodrow Wilson was president. Both of them together are at best 50% diagnostic for interproximal caries and occlusal caries. That's all in the literature. So we go digital, which doesn't necessarily add a component of better accuracy, but absolutely better communication, fluorescence, and then I get into transillumination for class 2s and far more. Not tonight's course. But when I can transilluminate a tooth in a video and see far more class 2 issues from an E1 to a D2, enamel, early enamel, deep enamel, early dentin, deep dentin, you could never see this on an x-ray. Digital records. I had 2 new patients today. I scanned both of them. I use iTero. There are many wonderful scanners out there. I'm using time-lapse to evaluate occlusion changes. I'm using time-lapse to look at recession. I'm using time-lapse to look at wear. Imagine when a patient says they don't grind and they're 30 and they come in every 6 months and we scan them next year, 1 year later, and the data can come out of how much tooth they've actually worn through. That's crazy. Cone beams and digital pans. All part of my initial exam. So look at the screen. And you're going to tell me that the average practitioner can offer this. And I'm going to tell you this is why I'm not the average practitioner, nor should you be. You're sharing your evening with me. So we use digital x-rays for X patients. We use fluorescence and transillumination for patients who don't have class 1 or class 2 restorations. Digital records are huge, and then cone beams, huge. And given a day, look at all the imaging and diagnostics we do. white are CBCTs for previous endos, implants, pathology. And then you look at all the bite wings we still take, and periapicals, and transillumination, and fluorescence. Are you kidding? This is modern day dentistry. And these are all covered in our in-office dental plan, by the way. I am absolutely anti-PPO. I'm not going to discount my work 50%. And all this just raises my bar to running a better business. So how often do you really need more information beyond a 2D image? Are you kidding? Here I am, it's not me, and I see squat so often on a 2D x-ray, squat. And I know I need more information, and I know something's there, I just don't see it. And if I pull it closer to my face, it doesn't change anything. So the first question at recall, are there any medical or dental changes? So my hygienists are all trained in this. And here's a patient who comes in, and her last recall, at her recall appointment, she said, I had pain last month in my upper left area. I was swollen. I took an antibiotic that I had at home. The hygienist does a percussion test, takes an x-ray, and sees nothing. There's the x-ray. Maybe you see a little something here. Maybe. Is that diagnostic? I don't think so. So number 13 had a bite change. Well, why would the bite change after 8 years and I had done the crown? Why would the bite change? Is there something apically pushing up 13? Or is there something else going on? I'm still guessing. So after I adjusted the bite, in the past, I would just wait because I'm not going to just open up a tooth with no symptoms. I just won't do that. But today what I do is I take a CBCT. So here's a scan, same day. Look at the difference. This is a 3D sagittal view of the same day I took the 2D x-ray. History of swelling. Come on. This is why I need the imaging. So I'm in a field of view, 5 by 5, smallest field of view. I don't need to get his whole face. And you can see the imaging of a small field of view versus a large field of view. Now, here's the added value. So let's say you see the abscess. And now the question is, do you want to do the endo? You go into the axial mode, which is looking down, top down from the occlusal view, and you scroll down, and you can evaluate the canal, and you can evaluate whether it's one canal all the way down, easy. I would do that. 2 canals that are separate, I would do that. But do they merge? Do they split? So if you see this and take an axial view and see that you have 2 canals, or one canal, let's say, and they split, that one canal splits into 2, you want to do the endo? I don't. Do I want to have 2 canals that merge and then split at the apex? I don't want to do that. That's failure for me. That goes to a microscopic endodontist in my practice. So not only do you see the image, now you can figure out, do you want to treat the image? This saves you time. There's no such thing as a good dental surprise. There's never. Do I want to go into one canal and see it split into 2 or 3? That's a crappy dental surprise. Now you don't have to guess. Now you know by looking at the axial view. I need to resume. Hold on. I think I lost control. There we go. So by the time I would have referred this out for a consult, get the information, I can complete this case and restore it, whether I need to do another crown or just restore the occlusal access. That's how fast this is. So you really talk about efficiency, check. Quality of care, check, because I got to diagnose it for $125. There's your code. And I decrease the cost of care to the patient because I know how to take care of this. Upper molars. How many of these do you see yearly. This is my buddy David. On a routine recall visit, his periapical shows this diffuse area above the mesiobuccal root. The root canal was done 20 years ago, and I can feel comfortable telling you this. I did that root canal 20 years ago. He has a history of on and off tenderness, no history of swelling, but there's that kind of funky radiolucency. No probings. Number 31 was missing, so I splinted the crowns 20 years ago. So that's my 20-year-old crown and bridge over my endo. Fine. Same visit, I take a 5x5 scan, high resolution. Now, this is how fast you can diagnose. What should be there? Right there should be your MB2 canal. I could never find them. I'm the first one to admit it. As you scroll deeper down, there's your abscess. If I scroll deeper down, you'll see more of an abscess. From the sagittal view, a little blurry, there's your abscess. So what does the literature say? Is this lesion worth retreating? The literature says it's essential to evaluate, and in the past we would take periapicals from different angles to see if we could find untreated canals. Remember that? The buccal rule of law, where you would just take a periapical from different views to find the canal. Today it's a cone beam. Before retreating any failing endo, we take a cone beam. Hone showed that retreatments involved 42% of missed canal. So in the Journal of Endodontics, 15 years ago, 42% of the time retreatments involved missing canals, and they recommended retreating because you missed the canal. What's the number one missed canal? 67% of the time with Lou Graham, MB2, higher with Lou Graham. So all I'm saying is the literature says retreat. How does that help the patient? Here's the retreat. It lowers the cost. The patient doesn't need an implant. Efficiency, I could diagnose it that day. Quality of care, proper decision making. Again, case by case. Anita and Perio Protect. Great patient. We had done ortho on her, restorative dentistry. She comes in every 3 months or 4 months for 49/10s. Just traditional periodontal maintenance therapy. So in the past year, we noticed that she was getting 5mm pockets, and she had nowhere. She had no 5mm pockets. So I put her on Perio Protect. Another course, another night. But honestly, you got to go check out perioprotect.com. So my hygienist calls me in to look at her. And now the 5s, which weren't even there a year and a half ago, are now 7s to 9s. And she's in Perio Protect. So the upper right area in green, now I have 7s. Everything else is perfect in her mouth. Well, why is it breaking down? Look at the 2D images. So I'm looking at this image right here going, well, she's got some pocketing, root proximity. Maybe we should do some periodontal surgery, ortolana. Just showing you the notes. She's in perio trays. I take a 3D scan, and there's your image. Up here is 2D, here is 3D. What are you going to do? Are you going to do endo and risk losing tooth number 2? Is this an endoperio lesion? Is this a J lesion? So I sent these images to my endodontist and periodontist. Here's the axial view. You scroll down and you can see where the bone loss is. My endodontist goes online, looks at the images, and says, take out the tooth. She fears that it's a J lesion and there may be a vertical root fracture. She's nervous that if she treats the endo and it's not successful, we may lose tooth number 2. So if we take it out, now the question is, what do you do? Well, I think this is the landmark study that we base what we do on. In Tarzana's studies, he found 93% success rate in immediate implants. 93%, but a higher percentage of failures in those patients with severe periodontal disease. So we decided, based on the literature, based on the cone beam, don't take it out. We took out the tooth, cleaned out the whole area, grafted, and then we placed the implant 4 months later. And now I got to restore it. Now, my periodontist does my implants and my prosthodontist does my surgeries, but I still work them up. And here's the challenge. This is totally offshoot of cone beams, but I'm sharing tonight. When you're seating a posterior implant like this in between two teeth, and it's a one-piece screw down that's got to pass passively through the contacts, through the tissue, which is 4 millimeters deep, into the hexagon internal. How do you know if everything's passive? You don't. So I totally do everything differently, and I take a hybrid approach. This is the two-piece approach where I have a crown with an access opening, a separate milled abutment, and what I'm going to do is I'm going to first put in the abutment. That allows me to know if I have a passive fit, because if I don't have a passive fit, I ultimately know it's going to rock loose and I'm going to lose bone. There's going to be a bacterial problem. I've got to have a passive fit. That's first. I need an occlusal access for retrievability. I can now try this crown on over this milled abutment and adjust the contacts. I have the ease of abutment placement because all I'm going to do is screw the abutment in and know if it's passive or not. Patients who can't open wide, I place this and then all I'm doing is trying in a crown. This then eliminates the path of draw issues. I've got to deal with the path of draw of the implant and the contacts. Man, this is really tough, really tough. That's why I take a hybrid approach. So this is the final sealed in hybrid implant. So I'm going to go back and just let you know how we do this. I'll go back one more. What we do is we try this in. This is my abbreviated quick 3 minutes. Then what we'll do is after this is tried in and I adjust the crown to make sure all the contacts and occlusion are great and take an x-ray, I put Teflon tape in here. I cement the crown in the mouth to the milled abutment. The Teflon tape protects the screw. I immediately, when I cement and I use Ceramer, I take a micro brush, clean out the access opening. Have the patient bite down on a cottonwood stick. 5 minutes later, I unscrew, and now I unscrew the crown and the milled abutment all in one piece. Clean out the excess cement, screw it into place, and then seal the access opening. So much more predictable. And that's the hybrid approach to a single unit, cemented and screwed into place. But ultimately, look at the cost savings. I could have done a root canal. I could have done periosurgery, and it could have all failed. This is efficiency, once again, quality of care, and diminishing failures. Diminishing failures lowers the cost to the patient. Let's talk about superior diagnostics. So here's a patient who comes in. He's 82 years old, and the crown on recall is moving up and down on tooth number 32. It's just moving up and down. The root's stable, you know that. The post got loose, the crown got loose. The periapical, you know, what's going on up here? I have no idea. So what do? You go in, take out the crown, try to put in another post, open this up. What do? You take a scan. He's 82 years old. He's in good health. Easily could have 10 to 15 years left in his lifespan. 2D imaging, not good enough. So this is what I do. I look at overall, there are 5 key things when I'm going to try to save a tooth. Does he have good buccal and lingual ferrule effect? The answer is no, so it's in red. Does he have good ferrule effect internally? You bet. He's got plenty of thickness. That's good. Am I going to violate his biologic width? You bet. Does he have crown to root ratio about 1:1? He did. But he's also missing his back teeth, so there's going to be far more occlusal forces on this tooth. Really not great. Let's scan him. So I scanned him. These are root canals. There's your gutta percha. I'm now looking down axially. Maybe there's a crack there. Maybe a crack. But as I scroll deeper, I start to see, I would say just an abscess or obviously radiolucent area on the distal. And so what do we see from the coronal view looking front to back? Here's the abscess wrapping around the buccal. Here's your buccal bone, wrapping around all the way to the lingual. So really, am I going to really be able to save this tooth with this short root, retreat this? I got to tell you, the literature demonstrates retreatments have a better success when addressing previously substandard treatments. Endodontic retreatments done on teeth with large periapical lesions have been shown to have worse prognosis, significantly worse. So what do we do? I just told him, I don't think it's worth redoing your root canals and putting a post in. Let's take out the tooth. I'd love to put a couple implants in. He said, let's just do one. So we took out the tooth. 2 months later, we grafted and did a sinus lift at the same time. 4 months after that, we placed his implants. We could have placed the implants when we did the graft and sinus lift per the literature, but my periodontist said he just wanted to wait. Do it 4 months later. And here we are 2 weeks ago. I don't have the final product. There's his scan body. We're just going to scan him. He's got a stable implant, and that's what I need in him. I need to hold this for the rest of his life. Better decision making, more efficient, quality of care. How do you make these decisions based on the 2D x-ray? There's my buddy Jim. He's the greatest guy. He's really a great guy. So we use a little cheesy social media, and it goes on the site. He's got 2 wonderful daughters in Houston. One runs a huge pediatric medical service at the University of Houston Medical School. She referred him to me. Great guy. And the cases go on and on and on. Resorption, external and internal. You cannot evaluate this 2-dimensionally. This is early resorption, moderate to advanced, and class 4 is good luck. How do you differentiate? So here's Dan. He's 51 years old. Tooth number 23 had endo done, turned yellow. Then endo was done on a non-vital tooth. They never knew why. Tooth number 22, no history, virgin tooth. Yet he had orthodontics done 42 years ago. Sorry, he's 61. No probing at all, none. This is under volume render. Look at the resorption. So here's your resorption right here. You can see the pulp chamber. That's the pulp chamber right there. Here's the money view. This is the coronal. So you can see when they did the ortho, this tooth is sitting way outside the bone. There is no bone here, none. And there's the pulp. So what did we do? We tested the pulp to see if it was vital, and it was non-vital. So the lesion is now going into the pulp. He's asymptomatic, non-vital. So now we see the buccal bone level. We knew that osteosurgery wasn't required. I just have to lay a flap. Now you take the axial view. You scroll down. You can actually see where the nerve involvement is. And then you can see where it is buccally based on the osseous location. And it was above the osseous level. So what do? I need to do endo. I need to do a repositioning flap. I need to restore the tooth. So this is what I came up with. This is how we treat these. I do an endodontic access first. I instrument the canal. Don't fill it. I instrument it. Then I lay a flap. So this is my periodontist and I. working together. I've already opened the tooth up. He lays the flap. Here's my file. Forget the rubber dam, get over it. And here's your canal right there. That was the resorption. I was not surprised. No surprises using a cone beam. Unbelievable accuracy. I use a little 1 to 50 epi to control the bleeding. I pack some biodentin into the area. Here's your biodentin. The bad thing is you got to wait 12 minutes. Boring. I told the patient I'll be back in 10 minutes. At the 12-minute mark, it sets. I then prepped it to create room for my composite. But here's the key. If you're packing biodentin in, we had to block the canal. That's why I did the endo first. I wanted to block that canal. So whether you use a paper point, which is what we did, or a gutta percha point, or the file or the paper point stops the biodentin from getting into the canal. So here's your paper point. I've controlled the bleeding. I etch the enamel only. That's selective etching. I use a universal bonding agent. I just scrub the area, high-speed suction, air, light cure. And I put 2 layers of G&EO flow in from GC America. Great flowable, bubble-free if you ask me. Here's the paper point. Endo next. Endo access after the endo. This is 3 weeks later. Now with the endo, we use calcium hydroxide therapy for 2 weeks. So let me go back. This is the final endo access. When we go endo next, we mean calcium hydroxide. We definitely want to minimize the resorption potential. And that's what he looks like 3 weeks later. That was done a year and a half ago. Looks great a year and a half later. I just need a new picture from Dan. Are you kidding me? Look what this CBCT did for me. The CBCT allowed me to understand what was going on, what I could see, how I could avoid any surprises. You could use MTA flow from Ultradent. It's probably how I'd go. It's much easier. 6-minute setting time to block the canal. And I'm just going to show you. Here's Eleanor. She just finished chemo radiation. I love her. Nicest lady. Brilliant history at the University of Chicago. Here's her periapical. That's funky looking. She has no pain or sensitivity. I'm so tough on my patients with hygiene. Look at that hygiene. But you see nothing on tooth number 22. Nothing. They're all in your practice. So here's a perio 3D on Prexion. There's your image. Can't miss it. How are you going to save this tooth? She just finished chemo and radiation. Here's your coronal view. Let's look at the sagittal view. Look at this thing. It's sitting just in this amount of bone into the nerve, asymptomatic. There's her axial view. How deep down as you scroll down, excuse me, do you see the damage? So I went back and looked at her periapicals. Here's 2013. Here's 17. I don't even see a difference. She's getting over chemo and radiation. No symptoms. We told her, if you get well, you survive your chemo and radiation, which we of course hope she does. We told her we may have to lose this tooth, but it was not worth treating based on the fact that we did not see a progression and the fact that she was asymptomatic. Yes, it was non-vital. Get over it. I'm just telling you, she concurred. Watch and wait. So as we get into this at the end of our course, how do you best buy a CBCT? If I haven't shown you enough reasons, how do you best buy? So the first thing I'm going to say is I'm going to start from the top, and I'm going to be really different. All you hear about from these companies is, oh, we have the lowest radiation or best images. Well, I'm going to start from the top. I think the most important thing is service, warranty, and training. I'm going to tell you again. You're about to spend 60, 70, 80,000 bucks. If they don't give you great service and extended warranty and training, I wouldn't buy the unit. I just wouldn't. I want to know, are the upgrades available? So if you buy one model and you want more, how much more do you have to spend? And then it's all about your rep. And I'm going to tell you, I have two cone beams. I'm going to brag about the latest one, and that's Prexion. I have two, and the other one's fine. But I have a rep named Krista. She's at my office when I need her. She helps train me. She's an amazing rep. She represents Prexion in the most incredible way. I've worked with 5 of the reps nationally, and there are other great reps out there for 3D companies. There are a lot of bad reps out there. I mean, I'm already on my second 2D because my first 2D before Dexis was terrible. The rep never came. You rep on 3D. Krista, I can't thank you enough. Ongoing education. There is so much education involved in this. I'm still learning. So you better make sure the company's going to educate you, have programs for you, online for you. Then you got to know your field of use. What do you need? Do you only need, like if you're an endodontist, you only need a 5x5. That's it. But if you're like me and you have other doctors in your office, you're going to need multiple fields of view. And then what are your upgrade options? How good are the quality of the images? And do the quality of the images relate to radiation? How much is the unit? Can you get good financing? And then I get to really interesting thing, ease of taking a scan. My team loves taking a Prexion scan. Now we'll look at other cone beam systems, but the Prexion, this Excelsior that we have is even better than the first one we had. And we upgraded and we paid the difference. And the ease of use, my team thinks it's the easiest thing in the world. And then how fast does the image convert? I mean, I'm looking at cone beams 5 minutes later. So let me just tell you this. You know, I watched John Julian's course, and I thought he was brilliant. John was great in the first course that was offered on Catapult. Kudos to John. And he talked about voxel size and focal spots, and do they matter? And they sure do. I'll show you. Because some companies will actually lower their radiation, but they'll be changing their voxel size or the focal spots. So you get a less quality image. Well, if you look at a voxel, as John told you, is a 3-dimensional pixel, and the focal spot becomes critical because the smaller the focal spot, look at this, the sharper the image. So just look at this one. This is a 3mm focal spot, and Prexion's not the only company with it, but they have a 3mm focal spot. So look at that image, and look really right here. Now let's go to the next one with a 0.5 focal spot. Now it's blurry. Let's go back. Not blurry, blurry. So companies offer different things. So Gendex has a 0.5. All of these have a 0.5. They're fine. Instrumentarium, really good, 0.5. Prexion and Newton, 0.3. Do I think they're clear images? I got to tell you, I think they're really clear images. So you have to go, what field of views do you need? Do you only need 2? You may only need 2. Don't spend the money to get 5. It's crazy. But is there an upgrade? And then you got to look at the range of images from HD to low dose. Some scans offer panorexes and bite wings. Are those important for you? And then you look at radiation doses. So here's my bottom line. And I know my time is my issue. It's always my issue. You got to have a 5x5. I don't care who you are. We use a lot of 10x5s to cover the whole arch. And then 10x8s we use a lot. 15x8s are really more for third molars. And 15x13s are really for TMJ and sleep. So I upgraded from this, and I added a 15x13 as we're getting into more sleep and TMJ. You got to have those upgrades available. You got to. And then you look at the different imaging. So on a 5x5, not to get technical, but the voxel size really becomes important because you want that quality of image. The voxel size gets to be a little bit larger, okay, as you go to larger scans. But what's really important is, when do I need a rapid on a young kid, third molars? When do I need a standard? When do I need an HD and an ultra HD? You need to have these reps come into your offices, show you what is open to all of you. I love the rapid for my patients under 20. It's minimum radiation. It's the same as a freaking Panorex. It's unbelievable. But I need HD or Ultra HD when I'm looking at a 5x5 trying to understand the defect. So I know what I'm looking for. And now that I'm on my third cone beam, I'm just going to tell you these become critical issues. And then the last thing is, can I be a better dentist? Can this help grow my practice? And I'm just going to end on this. We track everything. This is all dental intel. I'm a numbers guy. I'm in private practice. I have a group practice that I own. Patient comes in from the internet. I have 30 to 60 minutes to get their trust. Otherwise, they're going to go to another dentist. Harvard Business School shows trust and respect are everything. So she comes in. She's a Delta Dental patient. I don't take Delta Dental. Her previous dentist told her she couldn't have an implant. Told her that. And he was going to make her a 3-unit bridge. She had 4 bicuspid extractions, has a little TMJ issue from that. She has bilateral diastemas, but her history was a terrible history. She had an old amalgam, had a composite turned to endo, then he did a post and cork crown, and then she's got this. Of course I've got enough room. Are you kidding me? But here's what happens. Here's the magic. So she comes in, she's booked for a limited exam. And I knew she was coming in for a second opinion because we have a questionnaire. After I take the periapical, I send her for a cone beam. She comes back to my office and I sit her down next to me, and this is what I do. I open this up, and this takes the initial exam to the next level. I show her her scan. I show her how long her root is. I show her where her buccal bone is. She's going, this is unbelievable. I show her how wide the tooth is so I can know I can get an implant in there. And I don't place, but I don't have to place in order for me to wow her. And then all I do is I go to my BioHorizons screen. I hit implant. I hit planning, and I hit new. That's all I have to do. So she's sitting there, and then all I got to do is pick the length and the width of the implant. Easy. As soon as I pick it, I hit OK, and boom, it all comes up. All I do is rotate and play. I line the axial view up. I'll line up the sagittal, the coronal, and there's the 3D view. And all you do is rotate one, and they all rotate. It's really cool. And look how clear this picture is. This is a new patient. And then I just show her this. The implant was placed. Of course, she wowed him. We wowed her. She didn't want to think it over. She didn't want to do nothing. She didn't even go for another opinion. This is what happens. This is the value of a cone beam. She's a Delta Dental patient. I converted her. Here's my surgeon. Here's the treatment plan for the surgery. Then for my implant supported ground. She's a $6,100 patient. Wonderful person. Then I put her on my dental plan. She's going to drop Delta Dental. And tomorrow morning, I'm seeing her for Quadrant Dentistry for 3.5 hours before I fly to Raleigh. 88-year-old patient, last case. Her dentist told her there's something wrong on number 10. I just put this in today. Number 10, something's wrong. What do? I scan her. 10 minutes later, I'm looking at the scan. I line up the scan. So all I'm going to do is line up tooth number 10 with the root canal. Then I change the orientation. These are just my access lines. Here's the axial scroll down, and here's her abscess. Here's number 9. And as you learn this, now the abscess is spreading lingually all the way to the buccal. You'll see the buccal in a second. As I scroll mesial to distal in the coronal view, I can see if it's approximating the adjacent tooth. So as I'm scrolling, I can even see the buccal defect. right there, so I know I've got a deep buccal defect. This is the 3D perio mode in Prexion. I can open this, I can do scissors, but there's the defect. So here's the question. If you know you got a wraparound defect, and the endodontist wants to try and save it, and the surgeon doesn't, ultimately you as the general dentist have to sit down with the patient and in 10 minutes figure this out. CBCTs ultimately better the decision-making process, patient after patient. Okay, I know I went a little long. I know it's 7:57. Lisa and Shannon, I'll take questions, but thank you all. I know you're all busy. I worked all day today too. I just wanted to show you why I'm so into this technology. So the first question is, do you do a CBCT for every patient? Absolutely not. Every diagnostic thing I do has to be diagnostically driven for each patient. So no, I don't. But am I moving to low dose CBCTs? Am I doing that instead of Panorexes? Yes. Why? I see so much more on a low dose CBCT for the same microsievers that you do on a Panorex. So let's just say you got the same radiation level, which is low, really low. It's a third of an FMX is a low dose CBCT. Why would you take a Panorex when you can see so much more? Just letting you know. So that's my question. No, I do not take one on every patient. Any other questions at all? Those are the same two questions I just got. Anything else? Lisa, if there are no more questions, it's 8, and I think we placed a lot of information in everybody tonight. Thank you, everybody, for listening. You can contact, we'll have a handout ready for tomorrow. And if you need to email me, absolutely do it at lou@catapulteducation.com. It's my pleasure. Lisa, thanks for hosting. I hope it was worthwhile for everybody. You all have a great night. Thank you, everybody.